evening, everyone, and thank you for joining us. I am Eliza Moza, Clinical Manager for Europe and Middle East, and I will be your host tonight. Before we delve into tonight's session, just a little bit of housekeeping. First, I would like to remind you that this session is provided in German, Italian, and French. To access this, simply scan the QR code provided on the screen. Also, should you have any questions, please feel free to ask them by typing them in the chat, and we will go over them at the very end. With this being said, it is my great pleasure and honor that I introduce our esteemed speaker for today's webinar. His reputation precedes him. He is known for his sharp insights, innovative ideas, and engaging presence. Dr. Z brings a unique blend of expertise and charisma to our virtual stage. Dr. El Zoghbi earned his dental degree from the Lebanese University of Beirut and his master's degree in orthodontics and dentofacial orthopedics from the Paris University of France. After he finalized his studies, he completed a 2-year research program on biomaterials in orthodontics in the French National Health Research Institute, followed by a 4-year associate assistant lecturer in orthodontics at Paris 7 University, giving lectures for postgraduate students, along with providing orthodontic clinical training at the Hôtel Dieu de Paris Hospital in Paris. He is established in his private practice at Choisy-le-Roi in the suburbs of Paris and has treated over 1,000 patients with clear aligners. Since January 2020, we have the privilege of having him as a key expert and speaker for Spark Clear Aligner System, and is also responsible for Spark certifications in France. Get ready to be inspired, informed, and even entertained by our exceptional guest. Let's give a warm virtual welcome.
Thank you, Eliza, for this lovely introduction that I will somehow be completing on my own in a bit. But before we start, I would really, before we really ever start this webinar, I would like to thank the people behind the technical team, like Doris, Annabelle, Patrick, Lucher, Melanie. You are doing a great job, and I'm thanking you in advance because I'm sure it will be a success by the end. I will take also the time and advantage to thank all the ORMCO team, represented by Eliza here, to giving me the honor and the privilege to be the first to start the ball of this lovely education tour of 2024. As you see, we will be expecting 10 speakers this year, and I'll be the first launching this ball. And I'm really honored. I'm not shy, because as you know, in any ball or any dance, everybody's shy to start the dance. Everybody waiting for someone to start and giving them the motivation and energy so that everybody will follow. I am this one this year, and it will be very, very successful. And I'm not afraid of it simply because I'm not the shy type. And it's because of one other very good reason. It's because I will be having the best partner dance ever. And it's you, 1,500, approximately 1,500 people registered for this webinar that will be my partner in this dance, coming from apparently every part of the world. So I can even tell you all good evening, good afternoon, or even good morning. And I hope you'll be enjoying this topic with me. My name is Dr. Z, as Eliza told you earlier. I'll be going through this very quickly because she did a very marvelous job introducing me. I would just want to add one thing that she said correctly, but I have to give more details on it. Effectively, I have, since January 2020, around 1,100 cases ongoing with Spark aligners. But my background goes way back with aligners since 2005, effectively, where actually nowadays I have 2,200 ongoing and undergone treatments with aligners. So the experience goes a bit far. And I have seen this plastic evolving through the years. And all our protocols and our approaches to these treatment using aligners has changed a lot. And this webinar will be talking specifically on one good topic, and it is how to use aligners to correct class 2 malocclusions with a specific type of public, which is teenagers. Before we start, what are teenagers? We've all been there. we all know what teenage years are. Teenage years are a tough period because we have our bodies changing, our mindset is changing, we're discovering what maturity is, and all this brings some drama that we have to manage with our family, with our friends, with our teachers at school. So it is a tough crowd, and they're going through a tough time. Now, you take this drama and you add to it some crowding here, some overjet there, some deep bite, and really things go bananas. It's their life at that stage with all these malocclusions. It's like trapped in a very bad movie that's never ending. And yet we all know what it is being a teenager. We all at that age aspired and dreamt of becoming somehow the superhero versions of ourselves. And it's at that moment where we come in as orthodontists with our treatment plans. And it's at that moment where a webinar like this one comes in hand to describe how we can give these teenagers the best treatment possible that would be extremely predictable and extremely fast. And this is the basic topic of this webinar, where I'm going to be showing you two protocols that are extremely predictable that you can put in hand with your technicians to be very efficient in time and results to treat class 2 malocclusions with these teenagers. To get to deal with these two protocols that I'm going to give you and showing you some cases, we have to answer three different questions. The first would be, why do we want to correct these class 2 malocclusions? The second would be, when, and this is where the complexity of the questions start, and we will end with the how and showing you the two protocols. So if you want to start with the first question, which is the why, and that is somehow the easy question, because we all know why, but I want to put ourselves in a mindset and leveling somehow the conception of the why so that we will understand the how and the when afterwards. If you want to understand why do we correct class 2 malocclusions with these patients, instead of being them children like under 10 or even teenagers, we want to correct it mainly and firstly because of the risk of trauma that the upper incisors might be having. Because with a class 2 patient, as you all know, we will have an overjet, and these incisors will be flared forward, creating like a bumper shock, an absorbment of any shock that the patient might be having through his teenage years or when he is a child. So because of this overjet and because of these teeth outside the mouth, they are prone to break after any shock. So reducing the overjet, which is somehow pushing the mandible forward also, or reducing the overjet, will be putting these incisors back at bay in the mouth to protect them from any traumatism. And this is an article that's somehow recent. It says that, shows that comparing a class 1 to class 2, obviously the class 2 patients, especially class 2 div 1 patients, are more prone to have incisor trauma than a class 1 patient. So this is the first main reason why we do want to correct the class 2. The second very important reason is the masticatory function. Whenever we have a retruded mandible, geometrically, we have less contact points between the lower jaw and the upper jaw. And this leads to a less optimal masticatory function. If we push this mandible forward, and this article shows it, that when we protrude this mandible with whatever appliance we want, like a functional or orthopedic appliance, whenever we decrease the overjet and push this mandible forward, geometrically, we will have more contact points between the lower and the upper arch. And this is what this article gave as conclusion, that this masticatory function becomes more optimal if the patient has to have like 5 cycles before he swallows. Having more contact points allows this chewing to be more efficient, and we all know how interesting it is on the digestive level to have an efficient masticatory function. So this is the second important reason why we do want to correct this class 2. The third reason, and this is also no surprise, it's the airway space. Whenever we have a retruded mandible, we know that the tongue is distal positioned because of this retruded mandible, and the airway, the duct, the airway is reduced. Whenever we protrude this mandible forward and reduce the overjet, we will be increasing this airway and allowing for the patient to shift from a mouth breathing process to a nasal breathing. And effectively, it has something to do with the the future of the patient, allowing him not to have a future obstruction, OSA, later on in his life, or even some teenagers have OSA symptoms early in their life because of this retruded mandible. So this is a very nice chapter that was published in November 23 in the Current Principles and Techniques in Orthodontics. It's a book that has this chapter where it talks a lot about the effect and the correlation between the correction of the class 2 and the airway space, how you enhance it by pushing this mandible forward. And the last two reasons why we correct this class 2 is mainly aesthetic. Aesthetic because we push this mandible forward, so we'll have a better profile. Aesthetic because when the patient even is smiling, if he has a very strong class 2, we see that the lips are convex. Because when you look at him, he's not sad effectively, he's neutral, but yet he looks like he's sad because of the retruded mandible. The commissure of the lips just goes down and we have a convex smile curve. When we protrude this mandible forward, it gets straight. So if the patient is neutral, he would look neutral, or at least he wouldn't be looking sad. And then it's giving a more pleasant approach and more pleasant face whenever you abord this patient or talk to him. So for the aesthetic reasons, and adding also the aging process that is within the class 2, it is much faster than if we protrude this mandible forward early in the treatment. For both these reasons, and the aesthetics and the aging of the patient, we would be adding more reasons to early in the life of the patient, correcting this class 2 by mainly protruding the mandible forward, by pushing this mandible forward, by inducing this mandible to grow in the right direction. So these are the main reasons. And if you notice effectively what terms I was using describing the why, I was somehow mixing the words reduce the overjet and pushing the mandible forward, because these are two things that are linked, but yet they are totally different. Because this is where I will be introducing the when we want to correct this malocclusion, this class 2 malocclusion. Because depending on when you will be correcting it, you will be more doing a closure of the overjet, which is a resultant of a dentoalveolar effect, or you would be pushing this mandible forward because it's growing, and yet you have a dentoalveolar effect, but mainly a growth of the mandible where you are really at that stage touching the real cause and the real etiology of the class 2. Because we all know the etiology of the class 2, in like 90% of the cases, it's a retruded mandible. So if you go correcting it with any compensation, which is dentoalveolar, you're not really touching the real cause of the class 2, which is the retruded mandible. And here we open a very big chapter, which is the when. When I want to answer the when question, I love to go to the Bacchetti chart. The Bacchetti chart puts the patient's growth, especially on the mandible, on a curve. This curve will be telling you at what stage you are far before the growth spurt of the mandible, or when you are at the door of the growth spurt, when you are at the peak, or at the end when this door is closing. So we can divide the type of patients we have between the kids and the teenagers. The kids will be patients who are under 10 years old. That means they are somehow far between CS2 and CS3 of the Bacchetti chart. And the teenagers who have growth on their mandible, they'll be situated between CS3, CS4, and somehow CS5. And yet, both these patients, we will have to do a specific treatment for them to correct the class 2. With kids who are under 10 years old, who have a mixed dentition, and they come with a class 2 div 1, for instance, you have a big overjet, there is risk of traumatism of the incisors. The big question is, would you go close all the overjet with these patients? In my opinion, of course not. In these patients, we want to reduce the overjet. We want to intercept the class 2 by expanding the upper jaw, derotating the molars, yes, reducing the overjet by some dentoalveolar effect, putting some functional appliance, some myofunctional appliance if needed, because we are simply unlocking the growth that will be coming later in the later years, around 12, 13, and 14 years of age. But we will still treat this patient simply to intercept and to unlock the growth, expansion, reducing the overjet, and most importantly, derotating the molars, because we all know in these class 2 malocclusions, the molars are derotated with the medial in rotation. And this palatal cusp is creating a locking effect that will not allow the mandible to grow later on. So if you derotate these molars with mesial out, and I will explain this in a bit, when you derotate early, before 10 years old, the mesial out molar on these molars, you will allow the palatal cusp to be placed in a centric relation with the lower molar occlusal surface groove that will allow this mandible to grow forward without any interferences. So yes, we do look at the Bacchetti chart, and if I see that we are somehow at CS1, CS2, I would not go and push this mandible forward because it's not the time the mandible can grow. And I do not want to close all the overjet with a dentoalveolar effect, because if this is closed down completely, and when the patient comes at 12 and we want this mandible to grow forward for any aesthetic reasons, the overjet is not there anymore. So we do intercept this malocclusion by unlocking the potential of the growth, but it's at the teenage years where the real growth of the mandible and the real mechanics, like the class 2 mechanics or any appliance you're going to put in place, will be correcting the class 2 and bidentoalveolar, yes, but also you will have a big chunk of mandibular growth being present there because you unlocked it in advance, or you will be unlocking it at the right time at the teenage years. And this is why the question of the when is very important. When you are addressing real class 2 mechanics, it's not before 10 years old that you're going to put it. It's mainly at teenage years where you have to put all your energy and all your mechanics, all the weapons to correct the class 2, all at the same time to fully correct it. And that will be dentoalveolar, condylar growth, derotation of the molars, and even condylar repositioning that we'll see in a bit. So with that understood, let's go to the third question. And this is where the real mechanics will start. And this is where I'll be starting to explain in details these protocols that we're going to put in place, which is the first that mostly is applied to 80% of our patients. And yet there is this small category of patients that are somehow beyond the growth spurt that we're going to use another protocol that I'm going to show you in a bit that is inspired by the sagittal first approach, where both protocols will allow you to fix the class 2 and correct it at any teenage year. So how do we correct these class 2 patients with teenagers? First, we start with the easiest mechanic, which is the derotation of the molars. Then we have the dentoalveolar effect, which is the retraction of the whole upper arch and the protrusion of the whole lower arch, but that's on the dentoalveolar level. We have also the unlocking of the mandibular growth, which at that age is genetically present and programmed on the condyle and on the mandible. And we should always expect some slight condylar repositioning, because in any class 2 malocclusion, the condyle is distally positioned according to the disc, and any unlocking of the growth will allow also this condyle to go forward and contribute in the global correction of the class 2. So these are what teenage patients should be having in their prescriptions and in their protocols to correct the class 2. For you to understand how this is prescribed in a setup and how this is something that you have to communicate to your technician, you would understand that you have to ask the technician a set of aligners that will be divided into 2 chunks. The first part will be what I call the active stages. The second part would be the passive stages. The active stages, I call them prerequisites, because at that stage, from like 0 to 20 or 0 to 15, you will be doing a series of movements that I call prerequisite movements that will be preparing for the real class 2 mechanics coming in the passive stage. And this passive stage is where you are going to be putting real 6-ounce elastics to do your class 2 correction. Let's start with the first active phase, which are the prerequisite movements. What are these prerequisite movements? Mainly they are expansion on the upper arch. That means enlarging this upper arch to prepare the sparking for the car. This is how I explain it to the patients. So there is first expansion on the upper arch. This expansion on the upper arch can be uprighting, or it can be bodily movement and bodily expansion. You all know that if we want bodily expansion on the lateral segments of premolars and molars, we would be needing to add in our prescription buccal root torque to compensate for the tipping of the crowns because we don't want that, because if you dip the crowns, and if you procline the crowns and the palatal cusps dip, you will be increasing the bite and increasing the class 2. So first expansion, it can be uprighting and it can be bodily. If it is bodily expansion, you have to add buccal root torque and on molars and on premolars. So this is the first thing you have to do. Second, as I said earlier, you have to derotate the sixes. Derotating the sixes, you will be doing it with hinge axis rotation. You should tell your technician to do it with hinge axis rotation during expansion, in the sense of doing a mesial out rotation. This mesial out rotation, for many speakers around the world, it is contributing to the correction of the class 2, because when you do a mesial out rotation, your buccal mesial cusp is distalizing, which is true. But with teenagers, it is not really the main cause and the main reason of derotating these molars. When you do a mesial out on these molars, what you're effectively doing is you're putting your palatal cusp in a centric relation with the lower occlusal groove that will allow for a straight line for this mandible to grow forward without having this palatal cusp as interference of the growth. And this is something we've learned a long time ago with the edgewise technique and the Ricketts technique, where we derotate the molars to allow this palatal cusp to unlock the mandibular growth. So expansion, either uprighting or bodily, then we add buccal root torque. Then we do derotation of the sixes, mesial out. If we have the seventh would be doing a distal in to end up with a parabolic arch form. But also on the incisors, we need to overcorrect the overjet by 2 millimeters. What does that mean? In your prescription, you would go and check how much the class 2 is. If the class 2 is 4 millimeters, you would be needing to ask the technician to give you an overjet 2 millimeters more than what the class 2 is. That means 6 millimeters. If you have a full class 2 of 6 millimeters, you would ask the technician to give you 8 millimeters of overjet. So overcorrect the overjet. And you do it very early in the treatment for, again, 2 reasons. The first, because if you create a bigger overjet very early in the treatment, you would be allowing for the condylar repositioning to be applied and to express itself very early in the treatment when the patient is not even at the passive stages. And the second reason is when you get to the passive stages and you start with 6-ounce elastics, many times you have a very small loss of torque on these incisors. So if you procline them and overcorrect the overjet, you would be anticipating any loss of torque that would be happening later on in the passive stages when you start your 6-ounce elastics. So you put your overjet 2 millimeters and you have to level the curve spay. You want a flat curve spay that it can be done with any protocol you know. We do not have time today to talk about it. I'll be talking more about that during the Vista Summit in Barcelona in May. But you have to level the curve spay, either with premolar extrusion, the leveling of the curve of Wilson, or also the intrusion of the lower incisors. But these mechanics, no matter what type of protocol you're going to use to correct the leveling of the curve spay, you would be needing to add lingual root torque on the lower incisors during these active phases. So in your prescription, you ask for expansion, the buccal root torque, the derotation, the overjet, the leveling of the curve spay, plus lingual root torque on lower incisors. And here again, you need to put lingual root torque, active lingual root torque on your lower incisors, again, for 2 reasons. The first is simply because of what I call the cinch-back effect. The cinch-back effect is realizing that you're composing forces in a closed medium. This closed medium is like a cinch-back with wires that you bend the wire on the distal end of a 6 or a 7 that is blocking the perimeter of the arch. With aligners, you are constantly putting forces and putting force systems in a closed medium like a cinch-back, because every distal end of every molar and premolar and canine is like a cinch-back because the plastic is covering it. So all the system forces you are putting from the incisor to the molar is being expressed in a closed medium. To understand this in class 2 mechanics, let's imagine you put a class 2 elastic on this arch that is in a closed medium. This action of 6 ounces will reach the incisors, and yet this incisor cannot go forward because it's blocked with plastic. It cannot go backward because it's also blocked with plastic from behind. So this force has to express itself. This action reaches the incisors. There's a reaction according to the third law of Newton that's pushing it backward. this crown cannot go backward because of plastic, what eventually will happen is that this root will procline. And this is the law of Lavoisier that says nothing is lost, everything is transformed. This reaction, reaching the incisors, has to express itself at a point. It cannot express itself on the crown level because of the plastic covering and buccal and palatal, lingual, but eventually it has to express itself on the root level where there is osteoclasis. So eventually what will happen is that the roots will procline forward, and that's one of the reasons why we need to add active lingual root torque during the active phases to put this root at bay in the symphysis, because if not, it will procline forward, and after a couple of months of 6-ounce elastics, you will push the lip of the patient and you will see already all your roots having day senses on the lower arch. So this is the main reason. It's because of the cinch back effect where you're composing forces in a closed medium, and this with brackets, for instance, you don't have this, because in brackets, the wire, as it is not in a full size and full engagement in the bracket, you will still have the proclination of the incisors. But imagine if we were in a system where you have a full engagement of the wire and the bracket, and this wire is cinched back, you would have proclination of the roots. So this is the first reason why we need to put active lingual root torque on the lower incisors. The second reason for that is that at the first stages of the treatment, you are leveling the curve of Spey. When you are leveling the curve of Spey, you should imagine what the plastic is really doing. You should imagine that this plastic is with a flat curve of Spey. When you put it on the arch and you press it on the molar, on the premolars and the molars, it will be charging with energy, and this charging of energy will be decharging gently along the days of the aligner, pushing the premolars upward and pushing the incisors downward. So when you take the aligner that has the information of the leveling of a curve Spey, when you put it on the lower arch, it will touch first the incisors and the molars, and then the patient pushes it to plug it on the molars and premolars. And at that stage, the plastic will deform and being charged with energy that will be released to extrude the premolars and intrude the incisors after that. But at the first moment you charge this plastic on the arch, what happens is that suddenly you have a retroclination on the crowns and proclination on the roots, which are the effect of the deformation of the plastic when the patient will insert it. So every time your patient is taking a new aligner and plugging it on the molars and premolars and pushing it to fit, you will have right away the first 2-3 days buccal root torque on the lower incisors. And this is again a second reason why in your aligners, early in the treatment, during the active phases, you need to tell the technician to give you lingual root torque on these incisors. So these are the prerequisites, and the beauty of Spark is that we do not need to read in a very difficult way these lingual root torque or buccal root torque that you're going to have on the incisors, because the visibility of the roots is something that will aid you and make your reading of the force system much predictable and much easier to do than just looking at the table of movement, which mostly in most systems is wrong. If you take, for instance, these two setups, you have setup 1 and setup 2, where both present a leveling of the curve of Spey. We see that it's flat, and then we look at both the setups, we would imagine that they're exactly the same, while effectively they're not. Because of the visibility of the roots, you would understand and you'd be able to read the force systems present on this lower incisor and then choose the right setup for your patient. Because if you see setup 1, you have the roots that are proclined, even though the leveling of the curve of Spey is done, while in setup number 2, which is better, you have lingual root torque along the leveling of the curve of Spey that will put these roots at bay, because we do not want them during the 6-ounce elastic phase, the passive phase, of them proclining. So if you choose the setup number 1, you'd be sure that after 2-3 months of 6-ounce elastics, you will have day senses on lower incisors, while choosing setup 2 would put these incisors at bay and will protect them from being flared buccally and reducing the risk of day senses. And the beauty of the visibility of the roots is that you just look where they're going. You don't have to go to the table of movement and check the degrees and the orientation of these this force system on it. So these are the prerequisites. And then comes the choice of buttons and hooks and the choice of elastics you want to put for your patient. You have two choices. If the patient is in a class 2 div 1 configuration where the incisors are already flared forward, it's interesting to put a hook on the upper canine and a button on the lower molar and put these 6 ounce or 3 ounce elastics. We'll see in the timeline when and how to put them. But you imagine if you put a hook on the upper aligner, it's 6 ounces or 3.5 ounces that are engaging all the aligner backward. So this force is on the plastic, pushing all the plastic forward. So if you're in a class 2 div 1 configuration, this plastic will be pushed backward to reduce any excess overjet maybe you would have with this patient, or it is what it's best to do because you're pushing all the arch backward along with the incisors. Now, in class 2 div 2 patients, you have to understand what the first aligners are doing. The first aligners, or the active stages, effectively you are having pressure points coming from the palatal surface of the incisors, pushing them forward to transform your class 2-2 into a class 2-1 malocclusion. So if you put a hook and start your class 2 elastics early in the treatment, what happens is that your elastics would be pushing the incisors backward because this force is on the plastic pushing everything backward, but also you have pressure points pushing the incisors forward. So these two forces will be antagonistic and your incisor will not move. And you will see after 2-3 months of the beginning of the start of the treatment, you still have a deep bite and you still don't have the overjet needed for the class 2 correction. That's why in class 2 div 2 patients, you're better off with a button on the upper canine to allow the pressure points pushing the incisors forward, where it's the button that's pushing these teeth backwards. So if you want a small summary, just not thinking about biomechanics, suddenly if you want something more simplified on when to put a button and when to put a hook, this is a small table. You can have a screenshot of this table because it's a summary on when to put buttons, when to put hooks with class 2 mechanics. For instance, if you have the upper incisors that are proclined, better off with a hook. If they are retroclined, like class 2 div 2, you put a button. Also with the lower incisors, if your lower incisors are retroclined, sometimes it's more interesting to put a hook or an integrated hook on the lower molars because that all the plastic would be pushing these incisors forward. While if your incisors are straight or sometimes even proclined, it's better off to put a button on the molar so that you have the possibility to push these incisors downward and backward. Again, with the upper canines, if you have a canine that's highly positioned and mesially tipped, it's better off to put a button on it to push it downward and backward than putting a hook on it. And here again, there's some variations to this protocol. If you have a canine that's highly positioned and tipped mesial, sometimes it's even more interesting to put the button palatal so that, yes, this button will be pushing it downward, backward, but also allowing for a mesial in rotation to help the correction of the position of the canine. So this is a summary on the prerequisites, the active phase, then comes the choice of buttons and hooks for the class 2 mechanics, and then comes also the choice of the force of the elastics. And when we get to the timeline and the examples I'm going to show, you will see that we have two types of elastics. The elastics that are 3.5 ounces with orm code, these are the rabbit and the fox elastics that will be initiating the mechanics in the active phases, but then the real 6 ounce elastics, which are the real orthopedic elastics, will be at the passive stages, and then you would shift from fox and rabbit, you would be shifting to ram or impala elastics later on. So to understand how this protocol goes, let's take 2 examples. We'll take effectively 2 examples of 2 patients that are in a class 2 div 1 malocclusion. You will see that they're around 12, 13 years old. You will see also that even though they are in a class 2 div 1, they have also some proclination to do on the upper incisors because, as I said earlier in the prerequisites, we would want to have plus 2 millimeters the quantity of class 2. Patient number 1 has full class 2 canine and molar on both sides. You will see that patient number 2 has a subdivision right, where it's only on the right side where she's in a full class 2, while she's in a full class 1 on the left side. And you'll see that the timeline of the setup is exactly the same for both of them. It's simply the mechanics of the elastics that will be different from patient number 1 and patient number 2. So if we look at the Bacchetti chart, we will see that patient number 1, she's in a late CS2, so she's close to CS3, while patient number 2 is at early CS3. And we all know that the growth spurt from CS3 to CS5 is around a year. This is the lifespan of the mandibular growth curve. So both of them, they are at the doors of the growth spurt of the mandible. So we will be preparing the prerequisites. We'll be preparing the upper arch, the incisors, the lower arch, and then once they are getting close to this maximum spurt and the growth, we will be putting the 6-ounce elastics, and you will see in the timeline how it goes. If we look at the arches, we see that, especially in patient number 1, the arches are constricted, but in both situations, we see that we need to do mesial out rotations on these molars, because the position of the palatal cusp in this situation will be creating a locking and a resistance on the mandibular growth when it starts to express itself. And when we look at the incisors, we see some crowding for patient number 1, so we do want to procline the 11 to create more overjet. For patient number 2, we do want to procline and 11 and 21 to create a bigger overjet also. And like many class 2 DIV1 patients, there is no visible crowding on the lower incisors, and yet crowding is there because it is expressed by the extrusion of the lower canine to canine block. And this is what crowding is. It is also a curve of Spey. So here it is. It's evident by the deep bite both they have. So patient number 1 has deep bite, patient number 2 has even a stronger deep bite. And then we look at the class 2, full class 2 and on canine and on molars for patient number 1. And for patient number 2, we have a full class 2 only on the right side. But we see very, very quickly that for patient number 1, especially on the right side, we cannot expect this mandible to grow forward if we do not level the curve of Spey, because this will create interference with upper incisors when you put the class 2 elastics. So we have to intrude and retrude these incisors. But also, we need to procline the upper incisors to create a +2 overjet. So the same thing goes with patient number 2. You cannot imagine that this mandible can grow forward if you do not level the curve of Spey, and at the same time procline these incisors to create the sufficient overjet to have the condylar repositioning and also the mandibular growth. So this is the setup of how we ask the technician to give us the prerequisites. So we tell the technician, please expand upper and lower arches into Damon parabolic arch forms, do mesial out on 6s, distal in on 7th if they are in the arch, give buccal root torque to the lateral segments along with the expansion. You tell the technician to put buttons on the upper canines and on the lower molars. Now you know why, because in patient number 1, both canines were tipped. So we do want to put buttons on them because we want the elastic to contribute into the extrusion and the distal positioning of the canine. But also we want buttons on these upper canines because at the same time, during the active phases, we are proclining the incisor. So if I'm proclining the incisor and put a hook, that will be antagonistic to my proclination on the incisor. So buttons upper canine, buttons on lower molars. We procline the upper incisors to create a +2 overjet, expansion buccal root torque, mesial out rotation on 6s, distal in on 7th, while at the same time, as you look at the setup, we are intruding the lower incisors, extruding the premolars, but adding lingual root torque on both lower incisors to anticipate the cinch back effect and the insertion of the plastic and its deformation that will be inducing buccal torque on the lower incisors. So let's see what results we have. And this is in 10 months. That means in less than a year, we did get in patient number 1 from a full class 2 canine molar to a full class 1 canine molar in 10 months. And for patient number 2, we did the same thing. And this was possible in the timeline that we'll be seeing in a bit. And yet, when we look at the deep bite, we went from a very strong deep bite for patient number 2 and patient number 1. And in 10 months, we don't have any more a deep bite. When you look at the front view, we see that the incisors are intruded, the premolars are extruded, and the curves B is leveled, and that's leading to the correction of the deep bite. We all know also that the upper incisors are contributing also in the correction of the deep bite by the procrastination. This procrastination is usually done with uncontrolled tipping, and this will allow some relative intrusion on the upper incisors to contribute early in the treatment in the correction of the deep bite. And yet, when you look at this view of the front teeth, you will see that in 10 months, the treatment is done. We just have to remove the buttons. We can shift to hooks at that time, shift to class 2 elastics only at night, night wear, do some finishing, and we all know that in less than a year or a year, the treatment will be finished, while effectively these two cases are difficult cases. But it was possible because of the predictability of this protocol, where you prepare the arches in an active phase and then shift to 6-ounce elastics. So to understand this protocol on the timeline, now we know how to do it in a prescription. We know how to tell the technician to give us this protocol. We will have to see on the timeline how to implement it clinically in our patients. So first, the patient gets to your office. You have to bond the attachments from aligner number 1. I do bond the buttons at the same time because I take the advantage of the patient having the whole tray, the bonding tray present. I use this bonding tray once and bond everything from aligner number 1. So I put and the buttons and the attachments all at aligner number 1. In my office, what I usually do, and this is something generalized to all my patients, the patients start changing the aligner every 2 weeks. So we give them all the set of aligners, all boxes, and we tell them, come back in 8 weeks and change the aligner every 2 weeks. That means the patient, when they come back, they are usually at aligner number 4. During that phase, we slow down the change of aligners because we do understand that the osteoclasts needs time to be really stimulated and have all these cells engaged in the bone to start the remodeling of the teeth, the remodeling of the bone. So we do give time for this process to come at work and start its osteoclasts. So the patient comes back 8 weeks after the beginning of the treatment. He's at aligner number 4. We tell them, you're amazing, you are very serious. Now you shift to 1 week wear. And what happens for the class 2 patients that are teenagers, they will start changing the aligner every week, and they will be starting 3.5-ounce elastic only at night wear. Now, we all know that 3.5-ounce elastics are not orthopedic elastics. It's not the type of elastics that will allow you a dentoalveolar movement that's very strong. It's not the type of elastics that will be stimulating somehow the growth of the mandible. And yet, they're very interesting early in the treatment because they will have the possibility to allow the expression of any condylar repositioning to express itself, because this condyle is dormant. It's been retruded for a very long time, like 12 years. So even though you create the overjet, this condyle needs some aid, some help to reposition itself forward. So your class 2 elastics, 3.5 ounces that are worn nighttime, will be helping this condyle to be repositioned forward. The second reason you start your elastics 3.5 early in the treatment is to make the patient get used to the idea of wearing elastics, especially to get used to the idea of situating where the buttons should start. Sometimes the patients prefer to start from the molar and then the canines, others prefer canines to molar, so that when you get to real class 2 mechanics, they have the ability and the ease to put these elastics in a much easier way. At the end of the active stage, in this situation, it's aligner number 17, it's at that moment where there's nothing moving anymore. You are in passive stages. At that moment, your arches are expanded, your overjet is overcorrected, your curve B is leveled, you have your lower roots retroclined and put at bay in the symphysa. At that stage, your patient will be stopping the 3.5-ounce elastics and they will be putting 6-ounce elastic while they are changing the aligners every week. And these 6-ounce elastics are day and night. They change them twice. They wake up in the morning, they throw what they have at night, they put a 6-ounce elastic, they wear it all day through, and just before they go to sleep, they throw it and they take 2 new elastics to wear. and it's at around like 30 aligners, we would take these pictures and we'll get the full correction. So 30 aligners is approximately 9 to 10 months of treatment. And you will see by yourself, if you apply this protocol as it's in the prescription I showed you earlier, and you follow this timeline, there is no class 2 that cannot be corrected with teenagers. And you will see that your results will be extremely predictable in less than a year. Now, this is the first part of the webinar, because as you might think, there is some suspense in it, because we did deal with the question of patients who are at CS2 or early CS3. Why? Because as you might have noticed, the prerequisite phase will be taking around 6 to 8 months to finish. That means if your patient is at the doors of growth, it's at the doors of the growth spurt, that means early CS2, early CS3, or late CS2, early CS3, you would understand that the peak of growth is like 6 to 8 months further on. So if you are situated at that place where mainly these patients are between 11, 12 years old, or sometimes 13 years old, this is why age is not really important, it's mainly the Pachetti chart that's important, you can allow yourself to have the luxury to do all the prerequisite movements before your real 6-ounce elastics. And this is the biggest part of our patients. It's around 80% of our patients, because we do tend to see them early. So you go through the prescription, as we said earlier, you do your prerequisites, you do your active stages, and then you shift to the 6-ounce elastics later on and get your correction done. That's the majority of the patients. And yet, unfortunately, we do have some group of patients that we will tend to see later. That means maybe at 14, 15, 16, 17, no matter the age, but according to the Pachetti chart, they'd be somehow situated either at the peak of growth, that means between CS3 and CS4, or sometimes they are somehow in a late CS4 phase where the window of growth is narrowing and shutting down. So these patients, unfortunately, if you start doing your prerequisites and waste precious 6 to 8 months in the prerequisites and then shift to 6-ounce elastics, once these 6-ounce elastics are there to grow this mandible forward, well, unfortunately, at that moment, the growth isn't there anymore. That's why it's very interesting to find some sort of protocol that will allow us to neglect the prerequisites, think sagittal first from aligner number 1. That will allow us to right away and very early start with, from aligner number 1, 6-ounce elastics, using plastic, using aligners, without any other accessory other than the plastic and the elastic itself. So because of the problem I've seen with some of these patients, I used to put other appliances other than aligners to fix the malocclusion of class 2 with these patients that are somehow at the end of the growth curve. I decided to think of a way to mimic what works best in our profession, inspired by early elastics and the sagittal first approach, to treat these type of patients, where we see at the Pachetti chart, even though the first is 14 years old and second is 15 years old, you tell yourself, we have all the time for the growth to be applied. And yet, when we look at the Pachetti chart, we see that there's nothing left. They're really very, very early in their growth, and you don't have much time to do your prerequisites. So these type of patients pushed me to stop thinking of how I used to apply my mechanics and sit down and think and reflect in a way that I would be using only plastic and elastics to mimic the sagittal first approach and early elastics placed. And I came to create, along with the technicians of Spark, what I call the Z motion. It's called Z motion because my name is Dr. Z. Nice to meet you all. As I'm called Dr. Z, I called it Z motion. And you will see that it's a very intuitive, very simple protocol that we can put in place that will be somehow mimicking two principles that work very well in our profession with braces and others. And it's called the carry motion and the early elastic principle bonded together, but yet they will allow us to be doing it only with plastic and elastics. So how does this go? I will describe the protocol for you, and I will start with what two problems we had to face for the Z motion to work. Because by these two problems, you will understand the whole principle behind it. If you imagine putting 6 ounces from aligner number 1 from the canine to the molars. The problem with aligners is that the plastic is covering all the mesial and distal surfaces of the premolars from the canine until the molars, until you reach the molars. But this surface covering the premolars and molars until you reach the molar will be absorbing part of the 6 ounce elastics, and part of this force will be reaching the 6 being maybe 3 or 2 ounces even. Something that we don't have with the carrier motion. If you take the carrier motion and you plug it on the teeth, you bond it on the canine and the molars, what you will have is that you will have 6 ounce elastics transmitted right away from the canine to the molars without any loss of force, pushing the molar backward and derotating it mesial out. So we have this metallic beam that's transmitting the forces from the canine to the molars without getting any loss of forces that is engaged in the molars. Excuse me, in the premolars. Now we have a problem because with aligners we have the plastic covering these premolars, while with the carrier motion they're not touching the premolars. So one of the problems is to fix how we can find a way to not engage the premolars in these forces so that we have 6 ounces right away from the canine to the molars. One of the ways that we found that's really intuitive is simply oversizing virtually the premolars. That means when you send your STL files to the technician, on their screen, they will oversize the premolars, and they have the means to do it. So for instance, the premolar is like mesial, buccal lingual, like it's 5 millimeters. He will make it 6, and they will oversize these STL files only on the premolar level, so that when they print the molds with oversized premolars and then heat the sheets and thermoform them on this mold, and then they will cut it and you put it in the mouth of the patient, you will see that the premolars will be floating around this plastic. That means when you put the aligner on the teeth, they will be touching on canines and incisors and molars, but they will not be touching on the premolars. And by that, if you put a 6 ounce elastic on the canine, this 6 ounce elastics will be transmitted through the plastic until it reaches the molars, giving 6 ounces for the molars. So this is a way to mimic the carrier motion. And you will see also that there is another additional feature that you have to add on these premolars to mimic somehow this metallic beam. In the Z motion, it will be a plastic beam. But first, that was the first problem, and it is de-engaging the premolars in the whole process. The second problem was on the incisor level, because we do want to think sagittal first. Sagittal first means all the forces will be pushing only the lateral segments backward. While if you put an aligner that's covering all the teeth, all the incisors, and the canine and the molars, not the premolars, you would be understanding that this 6 ounce elastics are pushing all the arch backward, and the incisors are engaged in the retraction of the upper arch. And this is that's something we do not want to do, because we do not want this force to be also being absorbed by the incisors themselves. So we need to find a solution to somehow dissociate the anterior part of the segment from the lateral part of the segment. And the solution was found in the distalization protocol. We know that the distalization protocol, for it to be predictable, during the distalization of the molars, you would ask your technician to procline the incisors forward. Simply because, again, this is the third law of Newton. Pushing the molars backward is a force, is the action. The reaction is pushing the incisors forward. And these two forces will be somehow reciprocal. If you push the incisors forward and push the molars backward, this is something that would be very predictable on the incisor level and on the molar level. So these are predictable forces that are inspiring somehow the solution for this problem that we have, the Z motion. So what we will be asking the technician during the Z motion setup is to procline the upper incisors all through the class 2 elastic phases. That means there will be pressure points pushing the incisors forward, and this action pushing the incisors forward is also a reaction helping the teeth go backward. So not only we are dissociating by the proclination of the incisors, the anterior and the lateral segment, we are also creating an additional force helping the teeth to go backward, because any force pushing forward, third law of Newton, would be a force pushing the teeth backward. So this is how we fixed the two problems of the Z motion by oversizing the premolars to only have the forces going from the canine to the molars, and to dissociating the anterior part from the lateral segments. If you want to understand more how the Z motion works, you would have to look at the setup on the right side of the screen. So during the proclination of the incisors, that means during the pressure points you have on the incisors pushing forward, you would want to put a button mesial to the distal distal attachment on the canine. So this canine would be having a very long rectangular attachment bonded distal to the button. And distal to this attachment, you will be placing rectangular attachments on the premolars, but that you do not fill with resin. These horizontal attachments are just beams transmitting the forces distally. So you put your class 2 elastics, the canine wants to derotate distal in, the rectangular attachment will be resisting the distal in rotation, and by this resistance, it will be absorbing all the 6-ounce elastics exerted on the button, and this force will be transmitted from the distal surface of the vertical attachment all through the plastic beam until it reaches another mesially beveled attachment on the molar that will derotate this molar distal in and distalize it gradually. At the same time, this force, 6 ounces from aligner number 1, will be placed on the lower arch, pushing the lower arch forward, while at the same time you are leveling the overspay and extruding the premolars to correct the deep bite if you have a deep bite at that stage. But this is how it appears. You have one rectangular attachment distal to the button, and this should be a very long rectangular attachment. You have horizontal attachments that do not fill with resin, they are just the beam, and then you have a mesial attachment that will be playing the role of this hinge where you are derotating mesial out, distal in the rotation. If you want to see how it looks like in the mouth of the patient, this is how the Z motion would be. You have a big rectangular attachment distal to the button of the canine. You have a beam of plastic that you do not fill with resin, and this is the beam with oversized premolars. And on the molar, you have a mesially beveled attachment. Ideally, this setup, you would be using it day and night, because you will have all day long, the patient will be wearing 6-ounce elastics with a Trojan plastic. When he comes to nighttime and he wants to go to sleep, he will change the 6-ounce elastics and he will put new ones, and again he will continue with the Z motion. That means these elastics are being placed and day and night. Ideally, and this is something we're working very hard with the R&D team of Ormco and Spark, is to have something that will come in a synergistic manner, helping the Z motion to correct the class 2 in even faster ways. And it is by, hopefully in the future, introducing, along with the Z motion, some advancement fins, or like this anterior lock, like a twin block, that will be at night time pushing this mandible and locking it forward, along with the Z motion, so that both they'd be working synergistically to correct the class 2. If you want to understand how this Z motion is done, let's again see two types of patients that have somehow a huge resemblance with the two others. I've chosen these 4 patients on purpose for us to understand the difference between them, while effectively, when we look at their occlusions, they have the same occlusions. So patient number 1, she's just like patient number 2 on the other protocol. She has a class 2-1, but it's subdivision right. It's the same as the other patient earlier. Patient number 2, on the other hand, she has a full class 2 and on canine and on molars and also a deep bite, just like the other patient we saw earlier. The only difference is that this patient is 14 years old, the other is 15 years old. And if you look at their Bachetti chart, as I said earlier, yes, we do not have the luxury to do all the prerequisites and start our class 2 mechanics later in the passive stages. In both situations, we have a strong class 2, especially on patient number 2, and we see that it's a very strong class 2 because the Lewis is at 9, the MB is at 8. We have even proclined incisors and lower and upper. But both, they benefited from the Z motion, and we got to correct their class 2 in no time, in less than a year. When we look at the upper arches and we see the constriction of the arches, both patients need expansion, but we know that at that stage, we were not going to think transversal, we were only going to think sagittal. So we're putting the Z motion from canine to the molars, derotating the molars and distalizing them, while at the same time, we're proclining the upper incisors. On the lower arches, in this situation, we have some crowding. So in both situations, we are going through round-tripping protocol to level the curved spay, intruding the premolars and intruding the lower incisors. Here are the front views. We see that patient number 1 doesn't have much of a deep bite, but we see that there's a strong curved spay that we have to level. We see on the other patient number 2 that the curved spay is much, much bigger and the deep bite is present. And we see also that the class 2 is much more important for patient number 2. Patient number 1, class 1 on the left side, while class 2 on the right side, we have around 3 to 4 millimeter class 2 on the right side, while patient number 2, which we'll see, is a more representative patient on how efficient the Z motion is. She's in a full class 2 and on canine and on molars, and at the same time, we see that there is no overjet for this mandible to grow forward. That's why we will be very early proclining the incisors and doing the Z motion from aligner number 1. So do we go and do prerequisites? Let's forget the prerequisites, just concentrate on the sagittal first. Patient number 1 will be wearing day and night class 2 side elastics, 6 ounces. That means on the left side, on the right side, where she's in the full class 2, 6 ounce elastics day and night. But on the left side, she'd be wearing 3.5 elastics only at night, nightwear. The other patient in the other protocol that has a subdivision, right, was doing the same thing. She was wearing 6 ounce elastics day and night on the class 2 side. But do not forget that we have to put 3.5 ounce elastics on the class 1 side. Something that we don't see with brackets. With brackets, when the patient is in the class 1, the intercuspidation of this class 1 is your anchorage. So sometimes you don't need to put class 2 elastics to keep the class 1 in a class 1. The problem with align is when you put the plastic on the upper and lower jaw, you unlock this intercuspidation. So if you do not put elastics on the class 1 side, class 2 elastics on the one side, you might be losing this class 1 and ending with a very small class 2 in the end. That's why in aligners, class 2 subdivision, you should put class 2 elastics on the class 2 side day and night, and only at night you will be putting elastics on the class 1 side. Here again, with the patient number 2, we will not be doing the prerequisites. We're not going to deal with the transverse dimension. We'll be just thinking sagittal and putting 6 ounce elastics and day and night from aligner number 1. This is how the setup looks like. If you see the patient number 1, her premolars are not moving and they are oversized. In patient number 2, again, the premolars are not moving and they are oversized. While at the same time, we have buttons mesial to this vertical attachment that will be absorbing all the 6 ounces, transmitting it all through the plastic beam that we do not fill with resin until it reaches the molars, where we have this mesial surface of the bevel attachment, taking all the 6 ounce forces, derotating distal in, mesial out, and slightly distalizing. At the same time, as you see in the setups, we are proclining the incisors, and at the same time, from aligner number 1, we're leveling the curved spay. So all these are happening from aligner number 1 because the window of growth is closing. We want 6 ounce elastics to be applied very quickly on the lower arch. On the occlusal view, this is how you would see it. You would be proclining the upper incisors, you would be derotating the molars, and at the same time, leveling the curved spay on the lower arch. And you can ask even the technician to send you at the end of the setup some expansion on the lateral segments to end up protruding the upper incisors if they are already proclined. As you see in patient number 2, there is some slight expansion that you will see at the end of the setup, but not at the beginning, because at the beginning of the setup, around 20 to 25 stages, there is only sagittal first. So if you see patient number 1, in 3 months, you will see that the treatment is somehow finished. The overbite is corrected, the crowding is even corrected, and in 6 months, we ended the treatment. If you see on the lateral view, this is how the Z motion looks like. So the patient puts 6 ounce elastics from day 1. And as you see, around 3 months, the class 2 is being reduced. And in 6 months, the full class 2 was corrected, and the deep bite isn't there anymore. So this is a treatment that we would expect maybe to take a year, and then maybe starting finishing. And yet it's a very easy treatment because we've timed the elastics early in the treatment, and we've allowed this mandible to grow forward to contribute, along with the dilatation of the molars, along with the dental-alveolar effect, along with all these movements. The mandible growth was also contributing in the correction of the class 2. And this duration of 6 months is something we're used to with the sagittal first approach, because any sagittal first approach that we have with braces or even with aligners, we do get in 6 months full correction of the class 2. But what's most relevant is patient number 2. I'm sure everybody's interested to see what really happened with patient number 2, because this is where the real work is. She has a full class 2 and on canine and on molars. So let's see how it went. We have a retruded mandible. We don't have the upper wisdom teeth, which is good. When you look at her lateral cephs, yes, she has at the CS4 level. We have proclined upper incisors and lower incisors. We have an A and B at 8, and we have a very strong Lewis, which is at 9. And we know that we always have to correlate the A and B and the Lewis to understand how the class 2 is. Mostly the Lewis will be giving us an idea on the dental-alveolar component of the class 2. The A and B will be more giving us a skeletal interpretation of the class 2, but both they are working together, and dental-alveolar and skeletally, to make us understand where is this class 2. So this is a very strong class 2 with constricted arches. We derotate the molars, we procline the incisors. And this is a small summary on how it goes. And this is how the setup looks. We have the derotation of the molars, which is induced by the elastics, and the proclination of the incisor at the same time. On the lower arch, we're going to round tripping, intruding lower incisors and extruding the premolars, and doing some IPR halfway through, just before the second stage of round tripping. And as I told you earlier, the first stages of aligners would be simply sagittal first 6-ounce elastics. In some situations, we started putting rectangular vertical attachments, also palatal and mesial to the canines, to also be having these 6-ounce elastics, helping also the protrusion of the upper incisors, but also to help the locking of the canine in place and limiting the derotation, because 6-ounce elastics is a big force on this canine. It has tendency to derotate. So putting these rectangular attachments and mesial palatal and distal buccal will be resisting the rotation. But these are the first stages, just derotation and Z motion and distalization. But then I did ask the technician to give me at the end of the setup some slight expansion that will allow me, according to what I call the water balloon effect, some expansion to help me retrude the upper incisors back in place. If we see the before and after in the setup, we'd be expecting 3 millimeter correction of the class 2 simply by the Z motion, which is derotation and distalization, in about 6 months. So 3 millimeters is half the class 2. We'd be imagining some mandibular growth and also the derotation of the molars contributing in it. So we will still have like around 2 to 3 millimeters that we'll be expecting mandibular growth to contribute in the correction. This is the occlusal view, 3 months into treatment, and at the end of the treatment at 14 months, you will see that in 6 months we corrected the class 2, but we did order another set of aligners to stop sagittal first and concentrate on the transverse to end the treatment in a larger Damon arch form that is somehow parabolic. On the lower arch, we see that in 3 months, this is the first stage of round tripping. So we procline the incisors. At 3 months, we have at this stage to do our RPR and then intrude and retrude. And that's why at 14 months, we see that the lower incisors are leveled and retruded back according to the mandible angle. Front view, 3 months, the deep bite is being corrected. 6 months, you will see in a bit that we finished the treatment somehow in 6 months because the deep bite isn't there anymore. The curve of space is somehow leveled. We will see that 8 months into treatment, we went to refinements. We did some transversal expansion. And also the patient, just before we removed her attachments and buttons at 14 months, we did some gingival contouring to give her a good smile curve and on the gum and on the incisor level. But the most important pictures are here. We started the treatment at T0. We started 6-ounce elastics. 3 months into treatment, the left side is already in class 1. On the right side, we're halfway through. So we do understand that in barely 3 months, the treatment went from a difficult treatment to a very easy one. And in 6 months, we have full class 1 on both sides, and canine and molars. And this is what we were used to see with like the carrier motion applies. Now we're just mimicking it and calling it a Z motion, but yet the principles are still the same. 6-ounce elastics from aligner number 1. And that's 14 months into treatment. And this is the patient when we stop the treatment. So in about a year, a very strong class 2 deep bite malocclusion was corrected in a very predictable and efficient manner. If you want to see the superposition of this patient at the end of the treatment, we will be seeing that these angles that were like 8 degrees on the AMB shifted to 4 or like 5, 4.8, but the width went from 9 to -2. And this is something very important because these numbers, they talk a lot, because we do understand that the mandible growth did contribute in the correction because the AMB shifted from 8 to 4. We even see that we had a vertical growth of the patient, good for her because it's part of her growth spurt at this time. But what's most important is that the Lewitz went from 9 to -2. We all know that the Lewitz is also a skeletal reference for our class 2 or even our class 3s, but also the Lewitz tells us what dentoalveolar component of the class 2 is present. And when we see in this patient using the Z motion that the width went from 9 to -2, we would somehow understand that this opens a huge perspective and dimension, which is Z motion with adults. Because if the chunk of dentoalveolar with the Z motion is somehow present and important, we can imagine that the Z motion can be also applied to adults, where we want, along with distalization, to have a Z motion appliance placed to have a dentoalveolar compensation along with distalization, and that would be somehow reducing the duration of the distalization treatment, which you all know is about 1.5 years or 2 years to succeed. So by looking at these measurements, especially the widths, we would understand that the Z motion can be applied to adults, and this is something we're trying recently. This will be somehow the to be continued part of our lecture in the future, because the dentoalveolar component of the Z motion is very present, and this can be interesting for the adults. If I want to somehow conclude this webinar of today, it can be concluded in 3 take-home messages, of which these 3 take-home messages will conclude a 4th that is really very, very important. The first take-home message, I will not be going and concluding all the biomechanics because now you've understood them. I want to conclude that sometimes we do apply protocols that we have learned blindly, and we just maybe think that they would work for every single patient. But sometimes it's interesting to pause and to sit down, take a paper and a pen, and reflect on these protocols. And sometimes this constructive questioning would open new perspective and new dimensions for innovations, just like I showed you with the Z motion, because these innovations, especially in the aligner world, are somehow new, but because the aligner world is still somehow new, even though it's existing since 20 years, but there are plenty of new ideas that are just ready for the taking. And it just needs someone somewhere to sit down and reflect on them. And by that, creating new ideas that somehow can be inspired from successful practices that we have already in our field. So by this innovation, after that, you would understand that if we innovate and apply it in a more predictable manner, we would be somehow simplifying these protocols, because we do have complex protocols for correcting deep bites, class 2, distalization, and these protocols can be complex, but sometimes by simply reflecting and innovating, we can simplify and make easy what is already very hard. Even though it might fail the first time and second time, eventually we will succeed. And we will succeed for our own profession, but also mainly we will be succeeding for these group of patients, which are the teenagers. I started my lecture saying that they are a tough crowd. They are passing through a very difficult time. A lot of drama. So we come and tell them you have a 2-year treatment, and this adds to the drama, and it's not the time for it. So if we have in our hands techniques and protocols like the first I showed you and the Z motion I showed you later that will allow us to do this treatment in half the time, imagine how beautiful and interesting it is for this patient to give them the perfect smile they deserve, that will be empowering them and their self-esteem to face any challenge coming their way. Think of the parents, how extremely happy they would be from you, because you gave their kids the smile that will be helping them in their future to face any problem, as I said earlier. So I would love with that to end up my lecture, asking you if you want to ask any questions now with Eliza, it will be. But again, if you're interested to learn more about these protocols that I put in place during these 3 years I'm doing with Spark, you can join in any of the lectures we're doing in 2004. You check either the ORMCO website, or you can go to the Elevate page. Elevate page is the education page of ORMCO, where you have plenty of options for education. Or you can follow me. This is my world tour of 2024, and as you can see, I'll be traveling a lot in 2024. If you find yourself in any of these cities, just go on the ORMCO page or the Elevate page and register for any of the courses we're doing. One of the biggest courses we're doing is the AIM Masters, which is the Aligners Intensive Masters. It's my masters that go through 3 days and a half, where we're covering all the malocclusions with all the protocols, just as I showed you earlier. And if you do not have the possibility to join in any of the courses we're doing this year, you can simply scan this QR code. It's my Instagram page. And I do find myself even treating your patients on Instagram. I have treated around 100 patients on Instagram with people that I've seen my lectures. They just text me, they ask me questions, and we just exchange answers and experiences. So if you have some questions that you do not want to ask here now, just scan this QR code, and I'd be more than glad to be answering them all on Instagram. And with that, I would love to thank you all from myself and this lovely team for being here with us tonight, or this morning for those who are in their mornings. And I hope you liked this 1 hour and a half that we spent together on the Class 2 teenagers. Let's keep on changing their lives and making them this beautiful smile that will give them all the energy for their futures. Thank you. And by that, I'll be leaving the stage back to Eliza to see what type of questions you have for me.
Dr. Z, first of all, thank you for your insightful presentation. As usual, your expertise and knowledge on the topic were very enlightening and very engaging. We greatly appreciate you for sharing your valuable insights with us, and I am 100% sure that our doctors are really looking forward to implementing your advice on their own cases. We have many questions, so I've selected quite a few, some were repetitive, but we will go with the first few. So, hi, how much lingual root torque of lower incisor should I put? This was related to your slide where you had the list of prerequisites.
Okay. One thing I don't like, and all those who came to my courses who attended AIM, like we've done AIM 6 times until now, they will very quickly understand that I don't like numbers, because whenever you give a number, it becomes a recipe. There is no general rule. When your incisors are already proclined, you barely need any lingual root torque. So if you tell your technician, give me 4 or 5 degrees lingual root torque, that will be more than enough to keep your apex in the symphysa. In the other cases, where with deep bite cases you have retroclined incisors that are extruded, you should imagine that this apex is already proclined. It's already against the buccal cortical bone. That means this incisor, this root, needs way more lingual root torque than a flared incisor. So there is no general rule. You will have to look where the initial position of the root is, and by that, deciding how much lingual root torque to add. Retroclined incisors will be needing maybe 15 or 20 degrees lingual root torque, while proclined incisors will be needing barely 4 to 5 degrees. But there again, this is a complex question, because you would be leveling the curvature spare at the same time. So you would be undergoing your round tripping protocol. If your incisor is already proclined, would you go proclining it even more? That's the big question. In my cases, I wouldn't. If your incisor is retroclined and the apex already cortical, you would want it to procline, because the first stages of your round tripping will be already expressing lingual root torque, because you would be doing the first stage of round tripping by uncontrolled tipping. the uncontrolled tipping, where you're proclining this crown forward, while at the same time the root is going backward. And this is a big question because it opens the chapter of deep bites and the round tripping protocol that I'll be explaining in details during the Invista Summit in May in Barcelona. But if I want to be more general in the answer, it depends on how the incisors are. They are proclined, very little lingual root torque. If they are retroclined, bigger lingual root torque.
Okay, and a question that goes hand in hand with this one: how much buccal root torque when doing bodily expansion?
Okay, again, it depends on how the molars are. The general rule is you have to have 2 degrees lingual root torque with every aligner. Imagine if the molars are straight. That means in the perfect vertical dimension. When you start putting bodily movement and you ask your technician, imagine you ask your technician, expand 0.25 millimeters. That means it's the threshold of one single aligner. So you expand 0.25 millimeters. That means you need 2 degrees lingual root torque to be present on the root. So this is the general rule. So eventually, if you expand 0.5 millimeters, you need 4 degrees. If you expand even 1, you do the calculation. So the idea is that you have to think of the thresholds of this plastic. So every 0.25 millimeter bodily expansion, you would be needing 2 degrees lingual root torque to accompany this movement. Now, if you have uprighting, which is most of the cases that you've seen, the first 6, 7, 8 aligners, we only had uprighting, and there you don't need any buccal root torque. You start putting your buccal root torque only when you have bodily movement of expansion. So the general rule is 2 degrees per aligner of expansion.
Thank you. And because you've already mentioned the round tripping, here we have a question. What is round tripping protocol, please? Expansion and retraction of incisors?
The round tripping protocol is what we call in French le va-et-vient. That means you push a tooth on one side at specific stages, but then you have to bring it back. The round tripping protocol on the lower incisors, because the round tripping protocol can be at any part of the arches, upper, lower, molar incisors. On the lower incisors, the round tripping protocol is part of the deep bite correction protocol, where the first stage, you procline the incisors to create space and to relatively intrude the incisal edge. Then the second stage would be placing IPR to increase the spaces created. The third stage would be intruding and retruding the incisors while giving lingual root torque on the lower roots. So these are the 3 steps of the round tripping, and they are mainly used in the deep bite correction protocols.
Okay, thank you. And moving on to the class 2, and we're going into elastics, questions about integrated hooks versus the hook cutouts. You explained the rationale about using hook cutouts. However, how about integrated hooks?
There is nothing logical in saying that integrated hooks will be replacing buttons, because biomechanically they are contradictory in their roles. Integrated hooks can replace cutouts, yes, because the forces are applied on the plastic and on the cutouts and on the integrated hook. So if you have a class 2 div 1 with proclined incisors, you can put an integrated hook on the upper incisors because they'll be playing the role of a cutout. But if you have a class 2 div 2 patient and you're proclining the incisors to transform it into a class 2 div 1 patient, putting an integrated hook will be having the same antagonistic force of the proclination, just like a cutout. So hooks, integrated hooks and cutouts are exactly the same. You will have to decide when to use them. If you want an integrated hook, you have to have 0 movements on the incisors. And if you want to put an integrated hook on the lower molars, be sure that your red incisors are retroclined. But if you have proclined incisors, you would not go put an integrated hook on the lower molars because you would be proclining them even more.
Okay, thank you. Which protocol of class 2 elastics do you use for asymmetric class 2 cases? The class 1 side 24-hour light elastics or same elastics nighttime only?
When you're having an asymmetrical class 2, your mechanics should be asymmetrical. and in the force and in the duration. Both asymmetries should be present. That means on the class 1 side, you would be putting 3.5 elastics, the ounce elastics, and only nighttime. On the class 2 side, you would be putting 6-ounce elastics, day and night. So the asymmetric mechanics are in the force, it's 3.5, not 6, and it's in the duration, it's night wear and not full day, night and day.
Perfect, thank you. You've already touched a bit on this topic during your presentation. You explained the effect on the condyles, but it's good to hear a summary for this question. Did you face any TMJ problems with long-term elastics?
Okay, long-term elastics, where TMJ can be an issue is when you put 6-ounce elastics for a very long time. And this again goes to the effectiveness of your protocol. You do not want to go with 6-ounce elastics for a year, because obviously this will give you TMJ problems. You want to be as efficient and concise as possible. That's why the elastics, as you saw in my protocols, are not something that goes beyond the 6 months. In the first cases, it was about 3 to 4 months. In the second cases, where you have full class 2, like patient number 2, yes, this did go for 5 months to fully correct the class 2. But this is something concise. After that stage, yes, you would be imagining if you prolong this class 2 elastics of 6 ounces, you will have the contrary reaction of the condyle, because you do want this condyle to reposition itself and center according to the disc. But if you prolong the 6-ounce elastics more than 6 months, obviously this condyle will be anti-positioned, and then you will have clicking, and this disc will be compressed distally. So this is a very nice question. I thank the person who opened it, because you do not want protocols that engage 6-ounce elastics for more than 6 months, because eventually you will have TMJ problems. And this is one of the reasons why I do take time to think of how to do my protocols, because I want them to be efficient in a very short time.
Thank you for that. That was very, very helpful. Next is a question that I think I will answer myself. I was expecting it. Dr. Z, do you know when will the Z motion be available for our patients? I can answer to that question, and all I can say at the moment is that it's in the pipeline. Spark R&D, research and development, is working on it together with Dr. Z. So stay tuned. We are excited to come with a date as soon as possible. However, sticking to the Z motion, just so you know for when it's coming, can I put bike ramps with Z motion?
Well, bike ramps, again, there is a science behind bike ramps. Whenever you take this click and click on the button to ask bike ramps, many times, more than 80% of the times you click on the bike ramps, you are destroying all your biomechanics. You are destroying the proclination of the incisors. You are destroying the first stages of your round tripping blindly, without even noticing, simply because somewhere, somehow, someone told you put bike ramps for your mechanics. The choice of bike ramps should be placed at the situation where your upper incisors are already finishing their proclination, and also when you already finished the first stage of your round tripping. In these situations, ideally, you would be placing them on the canines and then shifting them on the incisors. In the latest cases I have with the Z motion, we are asking for these bike ramps to be placed on the canines, because they are helping this plastic to stay fit on the canines, but not at all on the upper incisors. Do not put them on the incisors very early. You would be shifting them later on in the stages. And this also is something that I spend a lot of time during AIM and explaining it to help you understand at what perfect and most optimal stage to shift it from the canine to the incisors. And this part of the lectures I do during the AIM courses also.
Thank you. You shared the case of a 13-year-old girl, the 13-year-old patient, and we have a question about that. Why did you use asymmetric virtual bite jump?
Asymmetrical, virtual
bite jump.
if you notice, there was an asymmetrical vertical sagittal jump effectively. These jumps are just virtual. Many times you do not, what is a jump? The jump is mandibular growth and condylar repositioning. There's not a single software, nor approver, nor any system in the world that can really tell you how this jump will be going. Your elastics, on the other hand, are orienting this jump to express itself. What you will have on the approver many times is not what really happens in the mouth. And that's the beauty of it. Clinically, you have to be seeing this patient often to sometimes change the wear of the elastics, shifting it sometimes you can shift it to a class 3, or maybe sometimes go to the class 1 side and pass to a 6-ounce elastics. So yes, the jump will be showing you what to expect, but clinically, this is related to the physiology of the patient, to the condyle position, to how he chews, how the muscles will be asymmetrically formatted during the aligner wear. And by that, you cannot guess by 100% how this jump will be. You would just be anticipating how it might be. That's why you have to regularly see the patient. We see the patient every 8 to 10 weeks to check, especially how they're wearing the aligners, how the class 2 is correcting, to at that moment decide if we need to shift the class 2 orientation or the elastic orientation.
Thank you. And we're going to have one last question related to your third case, where there was a functional component. On the before pictures, the midline was straight for the open bite and for the open picture, and shifted on the closed mouth photo. Do you ask the technicians to plan with this shift during the setup, or set the bite at the beginning to be centered?
Now, obviously, when you start your treatment, you have to be in a centric position. Ideally, also, you would tell the patient to wear a jig for a couple of months or 2 or 3, and then do the scans. With growing patients, I start the treatment right away because the aligners themselves will be unlocking the condyle. You have to understand that when you put a 0.5 aligner on the upper and lower arch, is somehow a disocclusion of the condyle, releasing it from the disc, and it is somehow the equivalent of splints that TMJ patients have. So with growing patients, I don't worry about the shift early in the treatment. I just start the treatment with the class 2 elastics, as I said, and it's the aligners that will be creating the role of these splints, something that you should not do with adults. When you're treating adults, you have to be sure that you are starting from a centric relation. With an adult patient, you would have to place him under a jig or a splint for a couple of months before starting the treatment, because you want to be starting from a true position, leveling the teeth and aligning them to finish in the same position, and not starting from a bad position to end up in the bad position. And so I don't mind this at all with teenagers, but with adults, yes, I do mind that, and I prepare somehow the patients with a jig before.
Thank you. I want to thank you, Dr. Z, again for all the insights, for sharing your knowledge with us. Again, I'm 100% sure that tomorrow, so many of our doctors are going to go to their Spark approvers and reevaluate all their setups. I want to thank our audience for staying here with us until the end. Thank you for all the questions. We really appreciate everything that you've sent our way. I'm sure that now you have even more questions, probably. Dr. Z has already shared with you the QR code on how to get in touch with him. Please do so. Please pick his brain. And again, thank you for joining us this evening, and we're looking forward to seeing you again in our next webinar. Have a good evening, everyone.